Hello, and welcome to today's presentation on the Quality Payment Program and what's new for 2019. My name is Elena Smith, and I am a quality consultant with MPro. First, I'm just going to go over a quick disclaimer. The content provided in this presentation is based on the latest information made available by the Centers for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for your interpretation and updates. For 2019 to 2024, CMS has outlined these 5 broad priorities for the Quality Innovation Network Quality Improvement Organization program. And those are improving behavioral health outcomes, focusing on decreased opioid misuse, increasing patient safety, increasing chronic disease self-management, increasing quality of care transitions, and improving long-term care quality. Lake Superior Quinn's partners MPro, Metastar, and Stratus Health would like to thank you for all of your hard work to advance the health and healthcare of your patients with us for the last 5 years. As we look to the future of improving quality on behalf of Medicare beneficiaries, our 3 organizations have entered into a new partnership called Superior Health Quality Alliance, which is strengthened by the addition of the Illinois Health and Hospital Association, Michigan Health and Hospital Association, Midwest Kidney Network, Minnesota Hospital Association, and Wisconsin Hospital Association. We each have success driving achievement of Medicare Quality Improvement Program Association as either a quality improvement organization, hospital innovation network, or end-stage renal disease network. Superior Health members currently improve healthcare in Illinois, Michigan, Minnesota, North Dakota, South Dakota, and Wisconsin, and have experience improving healthcare quality nationwide. As Superior Health, we aim to support the Centers for Medicare and Medicaid Services in improving the quality of health and healthcare delivery for healthcare consumers, providers, and communities in our region and across the United States. So today's presentation, we'll be talking about the changes to the 2019 Merit-Based Incentive Payment System, or MIPS. So first, we're going to get into the 2019 final rule highlights. So what are the goals for the 3rd year of the Quality Payment Program, which is 2019? So the goals are that the program's measures and activities are meaningful and to improve patient outcomes and reduce burden. So one of the things that changed is that there are newly eligible clinician types. So in the past, physicians, physician's assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists were all eligible clinician types for MIPS. This year, they've added physical therapists, occupational therapists, speech-language pathologists, audiologists, clinical psychologists, and registered dietitians or nutritional professionals to the list of eligible clinician types. So those are all the newly eligible clinician types, but it doesn't mean that they're all completely eligible. So clinicians and groups are excluded from MIPS in 2019 if they bill $90,000 or less in Medicare Part B allowed charges for covered professional services payable under the physician fee schedule, or furnish covered professional services to 200 or fewer Medicare Part B enrolled beneficiaries, or provide 200 or fewer covered professional services to Medicare Part B enrolled beneficiaries. So what does that mean exactly? Clinicians are then eligible for MIPS if do all 3 of these things. If they bill more than, or they do 201 Medicare Part B enrolled beneficiaries. So that's just the flip side of that. And how is that determined? So there are 2 MIPS determination periods. The first one looks at October 1st, 2017 to September 30th, 2018. And that is what you would currently see if you go on the participation status lookup tool. So the participation status lookup tool is a great tool. It's keeping track of all of these things on this last slide for you, so you don't have to. And that participation status lookup tool can be found on the qpp.cms.gov website under the MIPS portion. And it allows you to log in by adding in a clinician's NPI number. And it shows you the different TINs that clinician is involved in and lets you know if they are eligible in the determination period shown. So right now, if you were to go in and enter a clinician's NPI, you would see the details from the determination period of October 1st, 2017 to September 30th, 2018. Now later this year, likely in end of November or early December, the second determination period will be uploaded onto that website, and that will be October 1st, 2018 to September 30th, 2019. So CMS looks and tracks all of your data from those two determination periods to determine whether or not a clinician is eligible for MIPS based on those low volume thresholds we showed in the last slide. And clinicians must be eligible during both determination periods in order to be eligible for 2019 MIPS as a whole, unless you start a new TIN in there somewhere. So what does that look like? So this first clinician I'm showing you, they went on right now, they see that they're eligible, and then they go back in, maybe even in January before they go to report and see that they're again eligible. That would mean that overall for 2019, they are eligible and should be reporting for MIPS to avoid a negative payment adjustment. This second clinician developed a new TIN somewhere within the first determination period. So when they go in for the second determination period, it lists them as eligible. So overall, they are eligible. The next three clinicians at some point in time were not eligible, which means overall they're not eligible for MIPS. And the eligibility is determined for each TIN and PI combination. So a MIPS eligible clinician associated with multiple practices might be required to participate in MIPS at one practice and ineligible to participate as an individual at others. But again, that is all spelled out on that participation lookup tool, and it really breaks it down nicely by TIN. So what's another option for 2019? So in 2019, clinicians will have the option to opt in. So if a clinician exceeds one or two of the three low volume threshold criteria, they may opt in. So once a clinician opts in to 2019 MIPS, they are not able to opt out. So once you opt in to MIPS, you will be receiving a MIPS score and corresponding payment adjustment. And that again is something that is shown on the participation status lookup tool. If you enter in an NPI and that clinician is eligible for opt-in, that would mean that they are not MIPS eligible. So that's why you see the dark circles there for individual and group next to MIPS eligibility. But then the opt-in option shows that they are opt-in eligible as individual and group. So CMS they don't quite have the protocol down for how a clinician would choose to opt in. It might be something that is developed by the time the reporting period opens, and then that's how a clinician would opt in. But it is an option for 2019 if you are a clinician maybe that's voluntarily reported in the past and done well, and you want to maybe get a piece of that payment adjustment for 2019, opt-in is definitely going to be a great option for you. But just as another point, voluntarily reporting is also available. So again, if you are shown that you are not MIPS eligible, even if you are opt-in eligible, but you are not MIPS eligible, you will be able to voluntarily report, which means you report just like normal. You receive a MIPS score, but it doesn't come with a corresponding payment adjustment. So that's usually great for someone who hasn't ever reported for MIPS before, but expects to be eligible in a future year, so they want to see how they're doing. So what are the 2019 reporting options? So clinicians can report as an individual or as a group or as a virtual group, and clinicians participating as a group are assessed as a group across all four MIPS performance categories. And the same is true for clinicians participating as a virtual group. Another thing that I want to highlight are special statuses. So there are several different special statuses. I'm going to go through each one of these quickly. The first one is hospital-based, and if you are showing that you are hospital-based, and again, this would show up on that participation lookup tool. If it shows that you are hospital-based, what that means is that you provide 75% or more of your professional services at a specific place of service code. So those would be codes that CMS designates as hospital-based. And what that means is that your promoting interoperability category is related to the quality category. So you don't need to report on promoting interoperability, but you will need to report for quality to get those extra points. Then if it says that you are non-patient facing, that means that you're probably some type of clinician like a radiologist where you're not seeing patients directly. And again, that would mean that your promoting interoperability category is related to the quality category. The next one is small practice, and for small practices, that would mean that you are in a group of less than 15 or fewer clinicians, or maybe you're just an individual clinician in your TIN, and you will get 6 points added to the quality category, which I'll get into a little bit deeper within the next several slides. And then the last one is called facility-based. Now, facility-based is brand new for 2019. It is pretty similar to hospital-based in that, again, it means that 75% or more of your covered professional services are done at a place of service code that CMS deems as facility-based. And there is quite a bit of overlap in between hospital-based and facility-based codes. Those place of service codes, I think 3 of the 4 are the same. And the meaning for the facility-based designation is that the quality and cost category score would be determined by your facility's value-based purchasing score. So if you are facility-based, it likely will show a facility that you are attributed to, and that would be the score that you would be, that would be the facility that you kind of piggyback off of for your quality and cost score. So this is brand new for 2019, like I mentioned. CMS does definitely suggest that even if you are facility-based, still report your own quality data. Cost is something that's done behind the scenes, just in case your facility score isn't as high as what your individual score would be, or if for some reason your facility doesn't report for value-based purchasing for some reason. So you definitely want to have a backup for those, and CMS will always give you the higher of 2 scores. So even if you report for quality and your quality individual score is higher than the value-based purchasing score of your facility, they will give you the higher of those 2 scores. So MIP scoring for 2019 has slightly changed in that quality used to be worth 50% of your final score and is now worth 45%, and that extra 5% has moved over to the cost category. And that will continue to increase over the next several years, so taking from quality and adding to cost. So the performance threshold has also changed for 2019. So as you can see, in 2018, the performance threshold was set at 15 points. For 2019, the performance threshold is set at 30 points, so it has doubled in the past year. So what does that mean? So last year, as you can see, the improvement activities and the promoting interoperability measures are both worth what they are worth still this year. So oftentimes that meant that some clinicians only reported for improvement activities just to get to that 15-point mark so that they could avoid a negative payment adjustment. This year, that won't be possible. You won't just be able to get by reporting for improvement activities. You will have to have some other aspects of quality or promoting interoperability or a mixture of both in order to really capitalize on your score and get that 30 points. It is going to be considerably more difficult, and you have to be tracking things throughout the year to make sure you're reaching that 30 points. And the other part is that that score, that threshold, will continue to increase over time. So we want to really be capitalizing on our points each year, making sure that we get the highest score we possibly can so that we're getting the highest possible payment adjustment, which is that I'm going to talk about next. So the payment adjustment range has changed again for 2019. So in 2018, the payment adjustment for 2020 payment, because again, our payments always come 2 years after the actual year that we're gathering data. And that payment adjustment for 2020 payment year ranged from -5% to +5%. This year, that payment adjustment range could go from -7% to +7%. So that means if you're a clinician who is eligible and just chooses not to participate, you will automatically get that -7% payment adjustment. So we definitely want to be very conscious of all of this and making sure that we're really, like I said, capitalizing on our score, getting the highest score possible so that in the future years, we're just adding higher payment adjustments on. Now that we've kind of gone over the highlights of the 2019 program as a whole, I'm going to be getting into individual category. So to start, let's talk about the quality category. So within the quality category, a clinician can earn up to 45 MIPS percentage points. The performance period for the quality category is a full year. So what does that mean? For the quality category, clinicians need to be tracking their data from January 1st on. So this is something that I think gets missed pretty often by clinicians because we're so focused on reporting for the previous year that we're not as focused on making sure that we're getting our quality score up right at the very beginning of the year. So quality starts on January 1st and goes throughout the entire year. There are over 250 MIPS quality measures, So there are a lot to choose from. You can look at them all on the qpp.cms.gov website, again, under the MIPS side of things. And this year, what's new is that there are multiple collection types allowed. So if the same measure is submitted via multiple collection types, the one with the greatest number of measure achievement points will be selected for scoring. So what that means is if a clinician uses a QCDR to report their data, and they also use claims because they're a small practice, and claims is higher than the QCDR measure for one measure, and then it's opposite for another, CMS will go through and give you the highest possible score despite which collection type you use. So each individual measure could be using a different clinician or a different collection type. So that's a nice aspect to this year's methods. And definitely use that to your advantage if you have the ability to submit multiple collection types. So I kind of mentioned this in that last little slide, is that only small practices can submit via claims. So in the past, large practices were also able to do claims reporting. Starting in 2019, only small practices can submit via claims. So if you're a large practice that submitted via claims in previous years, you do have to find a different avenue to submit your quality measures. So for the quality category requirements, there are 6 measures required, including 1 outcome or 1 high priority measure, and specialty measure sets can be used. So if there are fewer than 6 measures available, clinicians must submit all measures in the measure sets. So for example, I think with radiation oncologists, their specialty measure set only has 3 measures within it. What that means is that those clinicians who choose to use a specialty measure set, which is completely fine, and clinicians oftentimes choose to do that, and CMS welcomes that, and that's why they exist. They do have to submit data for all 3 in that measure set. They can't pick and choose if one measure is low. They do have to submit for all 3. So this eligibility measure applicability process is also a new process, and it only applies to claims and CQM, or formerly registry reporting. So it's triggered if you don't submit enough measures or if you don't meet that requirement. Remember how I talked about 1 outcome or 1 high priority measure? So this is triggered if you don't submit enough measures or the required measures. And if the process finds more measures, they will adjust your scoring. So how do they do that? So at first they ask themselves these questions. Are there more clinically related quality measures to the 1 to 5 submitted because you didn't submit all 6? And then are any of the 6+ quality measures clinically related to an outcome or high priority measure? So that would be someone who submitted enough quality measures but didn't follow the requirements. So they would do a minimum threshold test for claims, and they ask themselves 20+ eligible instances that were not reported. For QCMs, or CQMs, excuse me, they ask, were there any clinically related measures submitted with a 0% reporting rate? So if a full measure set is submitted, because remember that one that I mentioned only had 3, the EMA process won't apply. So if you use a specialty measure set, you don't have to worry about the EMA process despite not having possibly 6 measures to submit on. And we suggest that you submit all measures that relate to your scope of practice and don't limit the submission to those that are clinically related. So how do you find your quality measures? So we want to go to that quality payment program website. And this website is truly a great resource for everything quality payment program. And it is qpp.cms.gov. You can see that up here. I show that you can click on the MIPS button, and there's that check participation status, and then explore measures and activities, which is what I'm showing here. You click explore measures and activities, you'll be able to search by measure type, specialty measure set, collection type. So whether you're doing CQMs or claims, you'll be able to search by all of that to find the measure that works best with your clinical practice. There are some bonus points available within the quality category. There are 2 bonus points for outcome/patient experience measures after the first required outcome measure is submitted. There are also 2 points for other high priority measures, and end-to-end cert reporting still provides bonus points. So what that means is you're submitting data directly to CMS without any manipulation of that data. And then bonus points continue to be capped at 10%. There's also the availability of the improvement percent score within the quality category. So this is based on improvements in total category score from 2018 MIP submission. So they'll look at your 2018 MIP submission and compare it to your 2019 MIP submission and possibly give you some improvement percent score because higher improvement will result in more points. And I'll kind of show you what that looks like here when I talk about the small practice bonus. So the small practice bonus is no longer 5 MIPS percentage points just added on your total score. So it used to be weighted a little bit heavier. This year they're kind of bringing in that and just adding it 6 points added to the quality category numerator. So what that looks like is quality performance will equal the total number of points you receive plus any bonus points. And if you're in a small practice, they'll add that small practice bonus there, all over the total available points within the quality category for your clinician. So if you're a special status like hospital-based, that might be a little higher. And then they'll add in any improvement percent score you might get, and that's how you will get your quality performance score. So clinicians in small practices must submit data on at least one quality measure to be eligible for the small practice bonus. So if you want to get those 6 points, you do have to submit some data within the quality category. So the cost category. So I'm not going to get too in-depth in the cost category because it is something that's done behind the scenes by CMS. It's not something that you would have to report on when the reporting window opens. But you are able to earn up to 15 MIPS percentage points. It will continue to increase to 30% by 2021. So I kind of mentioned that earlier in the presentation, that they'll continue to kind of steal from the quality category and give it to the cost category. So we definitely want to be putting this on the forefront. There is no data submission required, and the score is calculated from administrative claims if the case minimum of attributed patients is met. There are 2 measure scores that were used in previous years, and those are Medicare spending per beneficiary and total per capita cost measures. So I highly suggest that you go onto the qpp.cms.gov website and look at the cost category to kind of learn more about these 2 measures and these new 8-episode-based cost measures. So you can see here, several of these are procedural, and a few of them are acute inpatient medical conditions. So definitely take a look at some of the fact sheets that exist. If you go onto that qpp.cms.gov website, click on MIPS, and then click on the cost category, you'll be able to learn a lot more in-depth information on each of these measures. But again, they aren't something that you're actively reporting on. It's all stuff that's being done behind the scenes through your administrative claims. So now we're going to talk about the improvement activities category. You can earn up to 15 MIPS percentage points within this category. The performance period is 90 continuous days up to a full year. So you need to be tracking data for at least 90 continuous days, but could do a full year. There isn't really a benefit to doing the full year. It's not like you can get more points or anything like that. So we always highly suggest doing the 90 days. There are 118 MIPS improvement activities to choose from, and reporting continues by yes/no attestation. So what does that mean? Once the reporting window opens, you will log on and you will follow the instructions to make sure that you are linked to your practice. And then when you click on the improvement activities category, you'll be able to actually search for the improvement activities that you completed for the year. So, and you'll just click that you did it, and that's how that reporting goes. And for this year, promoting interoperability, bonus points have been removed. So there are 6 new improvement activities that were added for 2019. They are listed here. So if in the previous years you've been looking for a new improvement activity to submit, these are some good ones, and you can definitely read more about them on the QPP website to see if they fit in with your clinical practice. One thing I do want to note is that improvement activities, for the majority of improvement activities, they can be repeated year after year. Within the qpp.cms.gov website, it does note which ones are not available to repeat year after year, but the majority of them are available for completing each year. But definitely keep track of that. Make sure that when you are selecting your improvement activity, it's something that you didn't do last year, if that's not something you're allowed to do with that improvement activity, or maybe you're looking for one that you can continuously do and keep as a best practice within your practice. There were also 5 modified activities for 2019, and they are listed here. So if you attested yes to any of these improvement activities in the past, you will want to take a look at them again and make sure they still fit in with your clinical practice. With all of these improvement activities, you do need to have some form of proof that you completed them. So we always suggest that during the 90-day plus period that you select, that you are taking screenshots and you have a MIPS folder on your desktop that you're saving them into, just in case of an audit, that you can just send the digital copies over right away. So we highly suggest that. You do need to have some form of proof that you are completing all these improvement activities that you attest yes to. And then lastly, one improvement activity was removed. It was called Participation in Population Health Research, or IA_PM_9. And it was removed because it was very, very similar to another improvement activity which had the same name, Participation in Population Health Research, but it was called IA_PM_17. So if in previous years you were completing the IA_PM_9 activity, you will want to check out that IA_PM_ activity to make sure that you're still meeting all the requirements and keeping the correct proof that you need to show that you completed it. So definitely check that out if you were attesting yes to IA_PM_9 in the past. So how does scoring work for the improvement activities? So improvement activities can be one of two things. They can be medium weighted or high weighted. So medium weighted activities for a clinician in a large practice are worth 10 points, and high weighted activities are worth 20 points. And within the category, you need to receive 40 points to get full credit, which would give you 15 MIPS percentage points. So what that means is for a large practice, they either need to do 2 high weighted activities or 4 medium weighted activities, or 1 high and 2 medium weighted activities in order to reach full credit. For small practices, they are worth, those medium and high weighted activities are worth double. So medium weighted activities would then be worth 20 points, and high weighted activities would then be worth 40 points. So small practices and those in underserved or rural settings and non-patient facing clinicians or groups kind of have an easier way to reach that full 40 points because they only have to do 1 high weighted activity or 2 medium weighted activities. The other option is that clinicians in patient-centered medical home can attest yes to being in a patient-centered medical home model, and they'll get full credit automatically within the improvement activities section, so they get all 40 points, which is full credit. So that's all I have for the improvement activities section. For promoting interoperability, you can earn up to 25 MIPS percentage points. The performance period is, again, a 90 continuous day period up to a full year. Again, there is no extra benefit you would get from doing the full year outside of just having a little bit more data, but it won't give you an edge or extra points than just doing 90 continuous days. There is a maximum category score of 100 points, so once you reach 100 points, you will get those 25 MIPS percentage points. And then the bonus points, which I mentioned earlier from the improvement activities category, have been eliminated. For 2019, the Promoting Interoperability category has been redesigned to prioritize interoperability. And one of those things that came along with that is that for 2019, within the Promoting Interoperability category, 2015 Certified Electronic Health Record Technology is required to receive any points within the Promoting Interoperability category. So the caveat to that is that certification is not required until the last day of the performance period selected. So what does that mean? The last 90-day period of the year is October 3rd through December 31st. So if a clinician selected that 90-day period as the performance period for promoting interoperability, they would need to ensure that their vendor has a 2015 Certified Electronic Health Record Technology, or CERT, ready for use by October 3rd. but that vendor can have until December 31st of this year to make sure that it is certified. So if you're not sure about your cert status, if it's 2014 or 2015, we highly suggest that you start talking with your vendor, making sure that they are prepared for this, or if they have a plan for you, and start working with them closely. Obviously, October 3rd is coming up here pretty soon, so we definitely want to be on top of this in order to get some points within the promoting interoperability category. Because without this, you won't be able to get any points within promoting interoperability. So the exclusions for promoting interoperability. So the following eligible clinician types are excluded from promoting interoperability, and their score is reweighted automatically and shifted to the quality category. So some of these are special statuses like hospital-based clinicians and non-patient-facing clinicians and ambulatory surgical center-based MIPS eligible clinicians, and the rest of them are clinician types. So physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and then finally all of our newly eligible clinician types that we went over in the beginning of the presentation. So occupational therapists, clinical psychologists, speech language pathologists, registered dietitians or nutritional professionals, and physical therapists. So to earn a score greater than 0 for the promoting interoperability category, participants must, other than having 2015 cert, attest yes to these 3 questions: prevention of information blocking, which means you didn't turn off any functionality within your electronic health record that would prevent information from flowing. ONC direct review, which is if applicable, so you would know if that was you. Completing a security risk analysis during the calendar year in which the MIPS performance period occurs. So this is required every year. This is not new. You do have to complete an SRA each year and have proof that you completed it. And then reporting the required measures from each of the 4 objectives. So for the promoting interoperability objectives, there is e-prescribing, provider-to-patient exchange, health information exchange, and public health and clinical data exchange. And the e-prescribing does include the opioid measures, which are bonus or optional measures. So e-prescribing is the transmission of at least 1 e-prescription through CERT. Provider-to-patient exchange is the patient is provided timely access to view, download, and transmit his or her health information. Health information exchange, supporting electronic referral loops by receiving and incorporating health information for at least 1 electronic summary of care record received. The clinician conducts a clinical information reconciliation. And then on the flip side of that, support electronic referral loops by sending health information for at least 1 transition of care or referral. A summary of care is created using CERT and is then electronically exchanged. Then finally, the public health and clinical data exchange. So clinicians must be in active engagement with 2 of the following. So they have to be in active engagement with immunization registry reportings, public health registries, syndromic surveillance, clinical data registry, or electronic case reporting. So as you can see, some of them, like public health registries in the state of Michigan, have multiple to choose from. So being in active engagement with 2, you could choose 2 public health registries. So you could choose both MC, FP, and MAPS. So for the state of Michigan, we do have immunization registries, Michigan Care Improvement Registry, or MICR. We do have the Michigan Cancer Surveillance System, the Michigan Automated Prescription System, the Michigan Syndromic Surveillance System, which unfortunately no longer accepts data from clinicians in non-urgent care settings. We do have the Michigan Disease Surveillance System. And then finally, if you do utilize a QCDR, you can check with your vendor and they might have some clinical data registry reporting options. So clinicians are required to report on measures from each of the 4 objectives unless an exclusion is available. And then there are 2 new optional or bonus measures for the e-prescribing objective, and those are Query of Prescription Drug Monitoring Program, which is PDMP, or in the state of Michigan, we consider that MAPS, and then Verify Opioid Treatment Agreement. So one thing I do want to point out is if you are really looking to maximize on your points here, a great option would be to become in active engagement with MAPS, or Michigan Automated Prescription System. There are some improvement activities that have to do with MAPS. Obviously, this public health and clinical data exchange measure MAPS is included in. And then finally, this Query of Prescription Drug Monitoring program also includes maps. So it's a great way to really gain some points. And then some bonus points that just exist in MIPS overall are the complex patient bonus. So you can earn up to 5 bonus MIPS points proportional to the level of clinical complexity and risk of a clinician's patient population. And it's granted only if data is submitted for one of the categories that you submit data for, so quality improvement activities or promoting interoperability. And this is gained through hierarchical condition codes. So if you're doing those, you have the option to get some of these complex patient bonus points. I just want to also highlight some important dates for the 2019 reporting period. So on January 2nd, 2020, the 2019 MIPS performance period reporting window will open, and then it will close on March 31st, 2020. On July 1st, 2020, the 2019 MIPS performance data will be available on the QPP portal, so just in the same place that you logged in to report in between January 2nd and March 31st. And then finally, on January 1st, 2021, performance year 2019 payment adjustments will go into effect. So whatever you see that you'll be getting when you log in on July 1st, 2020, that's what will go into effect on January 1st, 2021. That's what I have for today's presentation. I just want to highlight a couple of resources that are available to you. For small practices of 15 and fewer clinicians, QPP STRS is available for technical assistance, and they can be found at the www.qppresourcecenter.com. And the STRS Health MIPS Estimator is another great resource. It's a free resource that allows you to plug in your MIPS data to see what a potential score might be. The QPP Help Desk is also available, and it is the technical assistance provider for large practices of 16 or more clinicians. And these are their details. They are available for Monday through Friday, 8 a.m. to 8 p.m. Eastern Time. Their phone number is 866-288-8292, and their email address is qpp@cms.hhs.gov. And again, you can find the CMS website, which has great resources at qpp.cms.gov. If you have any questions for me, my name is Elena Smith. I'm a quality consultant, and my email address is esmith@mpro.org, and my phone number is 248-465-1466. Thank you so much for joining me today. I hope you enjoy the rest of your day. Thank you.